So welcome to the Muslim Doctors Association COVID podcasts, where we'll be covering different topics around the pandemic. I'm Dr. Zaintu Khan, a GP and MDA's health promotion lead. Today, I'm joined by Dr. Bola Owolabi, the Director for Health Inequalities at NHS England and NHS Improvement. She's also a GP in the Midlands. Dr. Owolabi has particular interests in reducing health inequalities through integrated care models, service transformation, and using data and insights for quality improvement. Her previous roles include National Specialty Advisor for Older People and Integrated Person-Centred Care at NHS England and Improvement, where she led the anticipatory care workstream of the National Ageing Well programme. She has worked with teams across NHS England and NHS Improvement in the Department of Health and Social Care as part of the Covid-19 pandemic response. Thank you for joining us, Dr. Owolabi. We're fortunate to have someone with all your experience. Today, we'll be discussing the implications of COVID-19 on health inequalities. To start, I'm going to reference the Marmot Review 10 Years On, which was published in 2020. It highlighted how health inequalities had widened overall over the last decade. How has the pandemic contributed to widening health inequalities further?
So thank you very much for having me. It's a pleasure to be here. As you've referenced the Marmot Review, which is the 10 years on, the first review being in 2010, and then the follow-on published, as you say, last year, showing that there has indeed been a widening of the health inequalities gap. However, we also know, based on the PHE Public Health England publication last week around the health inequalities dashboard, we know that there has been a greater impact on health inequalities as a direct result of the COVID-19 pandemic. We know that the life expectancy gap has increased, particularly for women in the most deprived areas of the country. And so there is no doubt that the pandemic has had a significant impact on people's lives and their livelihoods. And as a result of that, it has shone a very harsh light on the pre-existing health inequalities within our communities. But I guess the other thing that I would say is that it was actually a great piece of foresight that the NHS in the long-term plan published in 2019, before the pandemic, already prioritized tackling health inequalities, which was a whole section of the NHS long-term plan. So although the pandemic has shown this really harsh light, and as I said, it has very sadly expanded the life expectancy gap, those worsening the pre-existing health inequalities. For me, it is comforting that in many ways the NHS was already on the front foot that through the publication of the long-term plan and the commitment, the clear commitment within that to tackling health inequalities.
That's great news. And were there any particular measures in the long-term plan and that commitment to tackling the health inequalities, any particular measures that would have been applied during the pandemic to reduce the exacerbation of these health inequalities?
So we know that the pandemic had a profound impact on the NHS and NHS services. And therefore, there were things actually that we were able to accelerate faster than planned. For example, the whole digital transformation. We've seen how many consultations, whether that is in primary care or indeed outpatients, were able to very rapidly move onto a digital platform. And some of those sorts of innovations that we thought might take 5 to 10 years actually were achieved within the space of a few months as a result of the pandemic. In terms of specific metrics, we know that there was a commitment to annual health checks for people with learning disability, for us to be able to achieve that at 67%. There was a commitment also to annual health checks for people with severe mental illness, and our ability to achieve 60% of that. There was a commitment in relation to maternity continuity of care plans, and for us to get to 35% at 31st of March, with a view particularly for women from a Black, Asian and ethnic minority community and those from the most deprived parts of the country, with a view to being able to achieve 75% coverage by 2023-24. And so there were some of those very clear metrics which again were repeated and amplified within the phase 3 letter. So listeners may be aware that in August last year, there was a phase 3 letter from NHS England, an improvement which set out the 8 urgent actions for tackling health inequalities. And again, amongst those 8 urgent actions was a reiteration of these commitments that I've just been outlining. We know that because the NHS has had to put up quite a response, to the pandemic, it has unfortunately slowed us down on some of these, but there is an absolute commitment that as we go forward into, the recovery phase of the NHS, that we will be holding true to the commitments that were set out within the long-term plan.
Okay, so it sounds like then you mentioned the recovery phase. So once, so hopefully with lockdown measures improving, like how has lockdown impacted? We talked about a bit of the pandemic affecting the health inequalities. Did lockdown also impact on those already experiencing inequalities? We talked about a bit about the livelihoods and it affecting the livelihoods. How has that affected the social determinants of health for people already experiencing health inequalities?
So we know that the pandemic itself and our efforts to address it have had some inadvertent impact. For example, loneliness. Many of whom live alone. So we know that there has been, exacerbation from a loneliness and isolation point of view for some sections of the community. We also know, again, particularly for older people, in terms of the impact on, their physical abilities and also their cognitive abilities, not being able to see people and interact in the way that they would have been able to do before the pandemic. We know that they have had difficulty and challenges in terms of their physical functioning as well as their cognitive functioning. There has been that impact on people's livelihood as a result of all of us having to do the right thing, which was to ensure social distancing. And of course, that has involved at different points, the lockdowns. But it's been important to see how, not necessarily the NHS now, but the government more broadly, the support that they've tried to put in place to mitigate people's livelihood. So has impacted on people, on their lives, on their livelihoods, on widening the health inequalities gaps as a result of that. But it's also important to note just the massive response that the NHS has stood up in addressing those challenges, particularly the extremely successful COVID vaccination program, which we are seeing, which is absolutely world leading. And so I think it's very important as we think about those adverse impacts that the pandemic has had, that we also have a focus on the areas where, the NHS has made tremendous progress in supporting people's health.
Absolutely. So you said the pandemic has brought these health inequalities into a sharper focus, but it's the commitment of the NHS and really like some of the resources pre-pandemic and some of the services were already stretched in general, and particularly in terms of health inequalities. But depending, bring that into, do you see that some of the services might be overstretched, or we've got that commitment that they'll be addressed over the next few years, that the plans that have already been put into place will be implemented over the next few years to avoid exacerbating health inequalities for the whole population?
So the NHS is working incredibly hard to make sure that we remain committed to the commitments set out within the NHS long-term plan. And also in terms of, just the sheer level of investment going to the NHS, and the absolute commitment and dedication on the part of the NHS to make sure that, hopefully as we begin to see, the glimmer of light at the end of the tunnel, which the vaccination program has offered us, this way out, there is no doubting the commitment and the determination of the NHS to make sure that, we do recover our services and that we do so in a way that does not exacerbate, those pre-existing health inequalities, but actually in a way that begins to address and to tackle them, actually by building important things that we have learned during this pandemic. We've built some powerful networks and partnerships and alliances with the faith community, with community leaders, with community action groups, which really is behind one of the great successes with the vaccine program. And there is an absolute determination that we are going to harness all of those learning, all of those partnerships, all of the networks and relationships in beginning to address and tackle the other health inequalities, because what we've learned is that actually by working with the community, we achieve a lot faster and we go further. And so there is a commitment absolutely to build on those important relationships that we've established during this period.
So it's said the pandemic has had some of the advantage of it was all of these collaborations, and you mentioned particularly the vaccination program, which is a success globally of the numbers of people reached. The thing with the vaccination program is there is a lot of news about the BAME communities, that they're less likely to have the vaccine, and has been circulating over the last few weeks. But are there any underlying factors contributing to this, and how should these factors be addressed to encourage more people to take the vaccination?
That's a really good question. So we know that there are two main things at the heart of the relatively lower uptake of the vaccination amongst some of our communities. And at the heart of it is the question of trust and also the issue of misinformation. Mm-hmm. And so one of the things that I have observed is that by working with those community leaders, working with the opinion influencers, really engaging in an authentic way with our communities, we have able, to start overcoming some of those mistrust that was there even prior to the pandemic. And I think as we begin to see the going up, I myself have been involved in loads and loads of webinars over the last several weeks, really engaging with the community, respectfully answering their questions, making them understand that, they have a right to ask questions, not dismissing what they have to say. And it's not just me. There have been lots and lots of other health leaders right across the country who have been doing some absolutely fantastic work, in engaging the community. I think by doing that, we have been able to speak to the mistrust that was there. And by engaging those community leaders, we're seeing that shift. Misinformation is the other thing. And I think, through the communications campaign, that the NHS has been running, lots of individuals and groups are going on TV and really speaking to that misinformation and busting those myths that have been going around. I think by tackling those two big issues in a collective way, we are making inroads and continue to make inroads into those communities that probably have had a lower uptake up until now.
Oh, that's very true. And with knowing that the theme of the trust and information, so what we've learned through the COVID and the myths, can we use any of the lessons learned in the pandemic to reach out to the minority communities, the main communities, to address other health issues, to also reduce or contribute in avoiding worsening the health inequalities?
Absolutely. I mean, to my mind, the greatest legacy of this pandemic is tackling health inequalities. Mm-hmm. And the thing is, there are so many things that have come out of this truly awful pandemic that in a paradoxical way, we can take with us into this next phase to tackle and address those wider health inequalities. So the brilliant creativity that we've seen, pop-up vaccine sites, roving vaccine buses, the use of places of worship and pop-up sites, just some example, fantastic innovation and creativity that we've seen. The huge role that health leaders from the community have played in speaking directly to the community. I don't think we've seen that on this scale before. It's another thing that I really believe that we can harness and build on to address those wider health inequalities. There is also, as I mentioned earlier on, the real engagement with community leaders, faith leaders, the opinion formers, engaging with the voice of the community. And I think by doing that, we've really ourselves in a position to be able to build on those strong foundations of innovation, creativity, relationship, collaboration, partnership, to now look at the wider health inequalities. And I remember one of the webinars that I was a panelist on, one of the bishops that was on it, one of the faith leaders was saying to me, why don't we now look at things like prostate cancer, and that in some communities the men are reluctant to come forward, to complain and to report their symptoms? And I said, absolutely, that's what we must do, is to take the learning, and take this relationship that we've built, to work together, to work with our communities, to begin to look at those pre-existing, long-standing health inequalities, because we've discovered that these things that have just been sitting out, that we have seen come through the pandemic, are powerful, powerful tools for us to deploy towards the other challenges around health inequalities.
You've used a lot of, as you said, the innovations, the partnerships, the collaborations, and all of that, and using all of that experiences that we've learned through the pandemic to tackle the health inequalities, one of which you mentioned is screening. Do you think that one area would be prioritized over another, considering that the gap in life expectancy has increased over the last decade, or there will be a plan to working on multiple health issues around at the same time?
So the thing that we must realize is in terms of prioritization, the NHS is committed to the whole health of the population. It's a service that has been set up from its inception to do that. And I don't believe that the pandemic is going to get us to a place where, the NHS is prioritizing one care over the other. Of course, we will have to be sensible. Of course, we would have to use the evidence base. Don't forget that it is a service that is driven by the evidence. What I will say is that the NHS will be, guided, informed by the evidence base to guide us in terms of what we address, how we address it. And I think listeners can be confident that whatever we do from this point going forward, as always, is going to be grounded in the best evidence that is available to us.
It's quite important in terms of using evidence-based, and we've talked about the digital transfer and more using technological innovations. Have there been any reports about access, improved access with using these innovative ways in terms of accessing healthcare in primary and secondary care?
So that's a very very good question, and I think I'm sure as the data starts to filter through, we will begin to see what it's telling us. But I can answer, say, from my own practice. Sometimes we risk assuming that certain groups and certain communities will be adversely impacted by us going onto a digital footprint. And yes, it may be that there are communities who perhaps have had difficulty in terms of their access as a result of us going digital. But an anecdote that I will share is around learning disability health checks. In my own practice, I was talking to one of my colleagues, GPs, only last week, and we were both reflecting on the fact that actually we have been able to achieve more with our learning disability health checks using the digital platform than we did without it. Because some of the feedback that carers have been given is that, being able to sit with their wards as we do the annual health check, at least some parts of it, not all of it, doing some parts of it using a remote consultation model has been actually very useful to them, because they haven't had to worry about getting to the practice and getting ready and the distress, of leaving home and so on. So that's an example of a group of patients that one could have assumed, would have been adversely impacted by, a digital approach. And actually quite the opposite is what we are observing. We do know from some of the data that is coming through that we have to be mindful. And you will note that the 8 urgent actions published in the phase 3 letter did talk about, restoring NHS services inclusively by making sure that we do focus on digital inclusion. So that was a very clear commitment within those 8 urgent actions tackling health inequalities. And so going forward, we will be keeping an eye on what the data is telling us about people's ability to access our services. And the other thing I just want to say is that the NHS is open, based on clinical assessment. If the right thing to do is for somebody to have a face-to-face appointment based on clinical grounds, then a face-to-face appointment will be offered. So I think it's really important to just reiterate that it's not as though we've gone to a blanket digital approach. It's there, it's a tool, it's working for some. There are some people that it won't work for. And for those that it doesn't work for, the NHS is open even for face-to-face consultations, where that is the right thing to do and where that is the clinically indicated way to go.
Thank you, Dr. Owolabi. So just in summary, I'm going to say that the pandemic has brought the health inequalities into a sharper focus, but it's also shown a lot of innovation, good partnership, a lot of community outreach, and the NHS commitment to provide universal healthcare to the population. Thanks you for your valuable insight, Dr. Owolabi. This is the time we've got for the podcast today. But thanks again for joining us on the MDA COVID-19 podcasts.
Thank you very much for having me.